I was asked to speak about mental health issues in kids, and as Ms. Ainsworth and his family and I talked about if we added a couple of topics about adolescent development, relevance to parents, to try to make it be especially useful. We'll cover those kinds of topics, as it says there. Something about normal development, mental health conditions and their scope. How do you get services, and what are the obstacles? Specifically, I'm going to cover some things on suicide and depression and anxiety, and then the use of professional help, what professional help consists of. But let me say too, you get a professional to come in here and talk with you about these kinds of things, and you're going to get a scientific perspective based on published literature, consensus in the field. You're going to hear some things about our professional experience and how we work and such, and that's useful. Don't ever sell short your own knowledge and expertise of your child. Real experts about your child are you and your child. And that's born out of your love for each other, your communication, your experiences together, your understanding of what the child's internal state is, what the child's behavior is about. Take the professional perspective, fertilize what you have, but you're the expert. And don't ever sell that short. Let's start off with some things about adolescent development. Adolescent is a transition from childhood to adulthood. It's about maturation, and the different aspects of maturation are, some of them are shown biological, of course sexual, but also other physiologic maturation, cognitive maturation, which includes awareness of self and others, abstract and contextual thinking capacity. You see that. When he's 12, he wants the next edition of the video game, and when he's 14, he's writing poetry and love songs. That's a cognitive maturation change, a sudden increase of awareness about this. There's social maturation, and it's a shift from parents to peers as providers of companionship and intimacy. And that's not necessarily a bad thing. This is preparation for adulthood, where the kids are going to be certainly relating to their peers and to other adults. The relationship with the parents is going to change as far as that exclusivity. That's normal and can be quite healthy. Usually is. Psychological development, there's self-image change, which is a lot about body image. Self-control has to develop, and that's a lot about impulse control then. Identity, which I'll touch on in just a second, the sensation of who I am and what I'm about. Kids develop skills and coping strategies, how to do things, how to solve problems, and they develop a sense of ideal self, kind of a standard that they're going to keep and compare themselves to as to whether they're meeting their ideals. Ways of judging themselves, which is about goals and purpose too. And then moral development, defining their values, beliefs, and their moral code, which gives parents a great deal of anxiety. But that's part of becoming an independent adult also. So those are some aspects of adolescent development and maturation. And Ms. Haley will chime in on some things if she has comments as I go with this. Specifically about identity development, we talk about identity as a sense of who am I, but it's a little more specific than that. I mean, the process is certainly of seeking and questioning, learning, weighing things and judging things, abstract things. Separating also is a part of the process, separating into a separate identity away from parents and away from part of the family and more toward an independent, autonomous adult. I think about the goal of the identity development process, certainly the discovery of direction and purpose in the individual's life. That has to happen. And then the other goal is going to be to develop a stable self, a self that is steady. You know mature adults, you think of them as predictable, dependable, reliable. You know who they are and how they're going to be. You count on that, and the adolescent has to develop that. That's going to go on really into their young adulthood, that process of development. But an integrated self that persists and is self-regulated. That's a big part of the maturation process in kids.
oftentimes we don't really see that until after they've graduated from college, because college is a real big time of the self-integration.
It begins in adolescence. You certainly feel it. You see it happening in front of you, sometimes frighteningly. Brain development, you get a physician talking, you gotta hear physiologic stuff, right? At least I'm gonna throw in some neurological terms, but at least I won't give you any brain pictures like I usually do. The prefrontal cortex is kind of the executive area of the brain, the one that kind of makes us adults. Cognitive control, reasoning, problem solving. That's a latecomer to the maturation party. It matures later than the amygdala. Amygdala is in the temporal lobe, the prefrontal cortex up here at the front. The amygdala and its related areas are about emotion, emotional reactivity, emotional sensitivity. Okay? And so there's an imbalance between those two about when they get there. Likewise, the ventral striatum, which is kind of some subcortical structures at the base of the cerebrum, which is about sensitivity to novelty and reward and threat, develops earlier than the prefrontal cortex also. Okay? So what do you get with that? Okay? The implication is impulse and emotion may dominate over reasoning and planning and self-control. Does that ring a bell? This is what kids are struggling with. They're emotional creatures and impulse-ridden creatures before they are thoughtful, reasoning, problem-solving, executive creatures. And that imbalance is tough. That's part of the developmental process. That's some of the intensity you're seeing. It's physiologically based. It's just about brain development. And it's a bigger imbalance in some than it is in others. I'll read this. You don't have to. Just look at the yellow on there. Okay. I put long quotes like this when they make a nice point that I can't make any better. As far as risk-taking, a study-supported view of adolescent brain development is characterized by a tension between early emerging, bottom-up systems, okay, that express exaggerated reactivity to motivational stimuli and emotion, versus later maturing top-down cognitive control, that prefrontal cortex. Okay, so there's a tension between the two, the early emerging and the later emerging. Okay, this bottom-up system, which is associated with sensation-seeking and risk-taking behavior, gradually loses its competitive edge with the progressive emergence of top-down regulation. So the prefrontal cortex is catching up. The executive adult brain part is catching up. But this imbalance between these developing systems during adolescence may lead to heightened vulnerability to risk-taking behaviors and increased susceptibility to motivational properties of substances of abuse and other things. Okay, does that make sense? Okay. This is the physiologic aspect, or the neurobiological aspect of adolescent development that's important, I think, in terms of what you see and what you worry about and how to manage. Okay. So what are the implications? Looking at how the developmental process is occurring in kids, what they're about, what they need, and then how the brain development aspects are going on. Okay, that kind of points pretty clearly. There's a continued need for supervision and structure and guidance and communication. Okay. This is not about intellect. Okay? Kids can be advanced intellectually and still be struggling considerably with that cognitive control, that executive control that comes later. Okay. The kids need limited choices until there's evidence of improving impulse control and judgment. So supervised opportunities for maturation, social and creative and moral. Supervised opportunities for many of the kids really are necessary beyond what the kids would like. You have to expect some emotional storms. Think about that imbalance between the emotional brain, the impulse brain, versus the reasoning, judging brain. And you're going to see some poor judgments. That's part of it. That's part of the learning process and part of the developmental process. It's not abnormal. As far as how to parent with this kind of stuff in mind, and using a mild emotional tone when correcting or confronting. I'm not saying be soft, okay? Be firm, but to use a low intensity emotional stress decision making and choices and consequences. Basically, you're trying to enhance and feed that cognitive control, that later developing part. there's pieces of it that are there, but it's not in charge. You want to try to strengthen it by how you parent. And also you want to avoid stepping into the emotional storm. So using that mild emotional tone. Okay. Keep in mind too that parent-child conflicts and arguments help serve that separation and individuation, that identity development process. There's a lot of the arguments that are so pointless and so annoying have a purpose in the bigger scheme of things. And you have to remind yourself of that. Easy for me to say. I only see him 20 minutes to 30 minutes at a time. Don't assume that the behavior and moods that you're seeing in your 14 or 15-year-old necessarily predicts the character of that 18-year-old. Things are changing. Okay? And change, a wise supervisor of mine once said that development is on your side and you had better be on its side. The process of change is generally toward that more mature reasoning and have faith.
I think one of the things that I've seen to be very effective has been for, as parents, we've all been through this before, so we really know what's coming most of the time. And so the student, the child, especially as they get up into high school and on into college, the relationship between the parent and the student has to change to be successful. Where the parent becomes more of a mentor to the child rather than the parent. There's a different role between the parent and the mentor. A child, as they're getting older, especially seniors and on into college, they're really looking for advice that they don't, through that separation piece, they don't want it to be a parent. And because most students in college do not live at home, if you haven't already built that mentor relationship, then it makes it very difficult to have that once they're gone. They find somebody else, and oftentimes it's somebody their own age. If they go to someplace like, A&M, they're at a campus with approximately 50,000 18 to 22-year-olds, and that's where they're getting their advice. So how can you help to start to build that process of helping them to think through? And I think one of the ways to do that is to pick out times when you've seen them make decisions, whether those decisions are good or whether those decisions are not so good. And ask a series of questions to them so they can start to think through. How did you come to make this decision? Where was the point when you had another decision and you chose not to take that other decision? What happened next? And so whether it's a good thing, whether it's a really positive decision that they made that was difficult, they had to think through, or whether it was a decision that you wish they'd chosen something else. If you only do that with poor decisions, then it feels like parenting again. It doesn't feel like sitting down and talking to somebody who's not judging them. Judging is the big right piece there. So I would really suggest that all parents start doing that probably about by at least the junior year. We really start asking them how they came to make certain decisions, whatever those happen to be, so that they can see that this is a process that they actually can control, that they do have choices, and that their reaction, whatever it was that they did, was actually a choice that they made based on several other choices that led up to it.
I would add, when you're doing that and you're trying to help them with this, again, keep the emotional intensity down, because otherwise you're creating a lot of emotional noise that's getting in the way of the message. Again, easier said than done, but it's worth striving for. I'll read this quote too. I think this encapsulates a lot from a study about adolescent development. Studies of parental influences on the development of competence in childhood demonstrate that children whose parents were authoritative, which is defined as warm and firm in research categorization, warm and firm, showed higher levels of competence and psychosocial maturity than their peers who'd been raised by parents who were permissive, authoritarian, or indifferent. Dozens of studies of adolescents and their parents have reached the same conclusion. So children at the top, adolescents here, namely that authoritative parenting, warm and firm, is associated with a wide range of psychological and social advantages in adolescence. The combination of parental responsiveness and demandingness simultaneously is consistently related to adolescent adjustment, school performance, and psychosocial maturity. Okay, warm and firm. If you looked up Love and Logic, the parenting program, that's kind of what that encapsulates it. Warm and firm. Parents worry about problem. Do I have a problem behavior or do I have normal behavior in my kid? So I put a few ideas together on that, which is kind of how we look at it clinically. Looking at the behaviors or emotions of concern as to how severe is it. Okay. When he got drunk, did he have alcohol poisoning? How dangerous was that? Duration and frequency. If he did he get real drunk once, or does he drink most weekends? And for a month he did it, or for 2 years he's been doing it. Age of onset or precursor characteristics. Is this mood difficulty I'm seeing in my child something I've been seeing since she was 4, when she had all these anxiety difficulties and emotional storms, and it's been kind of developing and now it's getting worse? Now I got something serious. Okay? Or is it this month during which she broke up with her boyfriend, and I haven't ever seen this before? Are there intrinsic vulnerabilities? Has this child been head injured before? Has there been epilepsy before? Does the child have ADHD or learning difficulties that increase vulnerability to these kinds of things, as you'll see? Is there significant interference in function? Is the fact that that I've got evidence that he's using marijuana now and then, is that also accompanied by an academic decline? Does it respond to consequences? Does the behavior of concern respond? Or does it continue on regardless of losing the car, losing the driver's license, losing the phone? Does it just keep on? Okay, so those are some ways to determine whether it's a problem behavior or whether it is more normal part of that developmental turmoil that may go on. Okay, I'm going to cover some of the mental health topics. Move away from the development down more into the mental health area. These are some of the common conditions that people might, in kids, the various conduct problems, including ADHD, depressive and bipolar disorders, basically mood difficulties, anxiety conditions, and there's all different flavors of anxiety that I'll cover later on. Trauma-related conditions, as you'll see here, trauma is ubiquitous in childhood. Autism spectrum increasingly recognized, and those kids who have autism spectrum, including some of the extraordinarily intelligent ones, oftentimes have comorbidities, co-occurring conditions like anxiety or depression, sleeping difficulties and such, and then other developmental disorders. We see a lot of kids who have severe developmental delays of various kinds. Thankfully, we see very few kids with psychotic disorders like schizophrenia, but there are some who have those serious mental illnesses that start in childhood. Eating disorders, bulimia, anorexia. Some kids with somatic symptom disorders, as they're termed, which is things like seizures that don't have a true epilepsy origin, body symptom conditions where no health problem is discovered, and then tick disorders like Tourette disorder. That's a kind of list of what comes around. How bad? How many? How big a scope of problems are they? These are all statistics, mostly from CDC and other government agencies that are quoted in various studies here. 1 in 7 kids 2 to 8 has a diagnosable condition. 1 in 5 kids 9 to 17 has a current diagnosable mental health disorder resulting in some impairment. And by adolescence, over 40% of kids will have met some diagnostic criterion, some criteria for some diagnostic, some condition at some point in life. Half of all emotional and behavior disorders begin by early adolescence, and 75% by young adulthood. Suicide is the second leading cause of death in the younger adolescent age group. When I was looking some of this stuff up, I was surprised to see 5 to 8% of kids attempt suicide yearly, and there's 1 million attempts in this country every year. That's CDC numbers. There's population surveys they do, so I hope they're pretty reliable. And then the tremendous academic impact of these kinds of conditions. Half of failures to graduate are attributed to psychiatric disorders in some studies. So the scope is pretty big. Lifetime prevalence is kind of, this is from CDC, it's a graph of the same thing I just told you there. About half the kids had something by the time in that 13, 18-year-old territory, and 21% have lifetime prevalence of a severe condition, severe depression, bipolar disorder, serious anxiety disorder, autism, things of that sort. Males and females have about the same prevalence rates for lifetime conditions, but they're very different types of conditions. The boys have more behavior difficulties and developmental disorders. The girls have more depression and anxiety conditions. And then the numbers rise, as you would expect, a few more every year affected, so the lifetime prevalence rates go up. So very common conditions. A little more about kids who have current diagnosis. ADHD about 6.8%, high percentage of other kinds of conduct problems. Anxiety disorders 3%, depression 2.1%. That's much lower than the population we're talking about tonight, because look at the numbers are compiled for age 3 to 17. Well, teenagers have way more, as you get ready to see, than little kids do. So the numbers for adolescents are way higher than that. And autism spectrum disorder is increasingly recognized as pretty frequent. It's up to 1.4% as of 2015 now, according to CDC. These are some numbers to look at teenagers with depression. 12-month prevalence, that is, in a 12-month period, how many kids have got it? 12.5% overall. Okay, so 12.5 out of 100. How many kids are in the school? Okay. Consider that then, right? 30 or so. 19.5% of girls in a 12-month period, 5.8% of boys. Again, that's kind of how it goes. And then look at the age of onset here, and we see this very much in the office. Early adolescence, and that's mostly girls. It starts emerging, and it really rises to fairly high levels there. It's present across all races and ethnic groups. So that's a common condition. And this is major depression. This is strictly defined meeting criteria. I'll show you those after a while. Anxiety disorders, similarly, 25% of kids 13 to 18 have had an anxiety disorder at some point in their life, and 5.9% have had a severe condition, severe anxiety condition. And I'll cover more about what anxiety disorders look like after a while. And like females more than males, it's fairly stable once it emerges, which is usually in late childhood to early adolescence. Okay, these are complex conditions too. Having a diagnosis is not the end of the story. Comorbidity, which is a term meaning more than one diagnosis, more than one condition, is very common. I'll look at my patient list today. I had a medical student with me, and he kept shaking his head. Because the kids all had 2 or 3 diagnoses. It just was one of those days with more complex kids coming in. But ADHD, for example, having ADHD means you have higher risk of depression, higher risk of anxiety disorder, higher risk of opposition to defiant features, learning disabilities, higher risk of bipolar disorder. So they go together. They also change over time. That's complicated. Some of them get better. About half the kids with ADHD and some of the kids with anxiety conditions get better in teen years. Some get worse. Bipolar disorder and autism may worsen during adolescence. And they may shift in pattern. For example, little kids with anxiety conditions have fairly high rates of showing up as depression in teenage years. Okay? So the same child may look very different from one age to another. And then you see brand new syndromes emerging. I get to see this. I've been here a long time. I've watched kids grow up under my care, and they surprise me. I mean, it's in the literature. I know the risk is there, but I'm no good at predicting this. I found. I sit back and watch. Depression starts up in a kid with ADHD. Tourette disorder starts up in a kid with ADHD. We had a patient with high-functioning autism who comes in with a new severe anxiety condition. This is important, I think, in terms of why does this happen to kids? Some of it's genetic, of course, but a lot of this is experiential. These are risk factors for kids with these conditions. And look, these are studies looking at kids, teenagers, high school students, 1 year prevalence. In any 1 year, how many of them experience these things? 15.5% electronic bullying, 20% bullying on school property. And as we in East Texas have learned painfully, bullying is significantly associated with suicide. We'll come to that later too. Substance use in any 1 year, 32% of the teenagers are using alcohol and 22% marijuana. And that's CDC type statistics. 1 year prevalence, that is, again, any 1 year in kids 0 to 17, all children. Okay? 1 year prevalence of violence. 37% experience a physical assault in any 1 year, 9.3% are injured in the assault. How about sexual abuse? 2% of girls in any 1 year. 4.6% of girls during their teen years, sexual assault or sexual abuse in a year. Maltreatment by a caregiver, 15.2% in a year. They've got specific definitions of what maltreatment is, which I won't go into here, but for research purposes. 5.8% of kids in a year witness parental violence in their home. Okay? And then lifetime, this is lifetime now, not the 1 year prevalence. Has it ever happened to you? Sexual assault. 6% of boys, of girls aged 14 to 17, 14.3% have been sexually assaulted. 4.5% of girls 14 to 17 have been raped. So those are our risk factors. It's pretty grim. But that's what the kids are experiencing, and that's kind of the kinds of conditions they have and how frequent they are. Thankfully, when your child experiences some of these things, you're going to get them to a mental health professional, right? Probably not. Access to care is a national problem in child mental health. In our office, and this is the way it is nationally, if a kid gets referred to me by a pediatrician, family physician, and such, a counselor in town, the wait is going to be 3 to 12 months before they get in. New patient I saw Monday was referred last March. It takes that long, and that's all over the country. This happened by design. There were policy decisions back in the 1980s and 90s to drastically cut funding for mental health services and to cut training funding, and training positions diminished. And you would have to say that the policymakers at the national level and in the insurance industry were very successful in what they set out to do. So here we are with it now. Into the mid-2000s, Texas was actually losing mental health professionals, not just psychiatrists, but psychologists and counselors. The numbers were diminishing. That has begun to reverse. Our legislature has seen the light. They looked at some pretty scary statistics, which is that, I know psychiatry because that's what I do, half of the psychiatrists in Texas are over 55. And child psychiatrists, my age group is the biggest age cohort that there is, and we are now in the process of dying and retiring. While the numbers of training have increased some, that's not going to keep up. So this will not be a problem that is solved during our lifetimes, unless the robots and the geneticists fix it all for us. What we have in East Texas, I'm sorry, our legislature has seen the light about this and has funded more training programs, including at UT Health, for psychology interns, for psychiatrists. So the numbers are starting to get a little better in Texas, but that's a long process. What we have in East Texas is pretty much the same as the national status. The primary caregivers for mental health services are the primary care providers. Your pediatrician, your family physician, nurse practitioner. Community mental health centers like Andrews Center, Access, do a wonderful job with their priority population, which is severely mentally ill kids that need this, and a lot more will get picked up now and get referred and they get in line. Some schools are doing screening as well. And then the idea is provide universal services, pick out the ones who need something extra, and then try to get them a little more individually assessed and try to maybe address any specific problems they're having. And then only send the ones with more intensive needs onto specific mental health services. That approach works if you can just get everything lined up. It's a big project a lot of times. It's been implemented in primary care to a large degree. Okay, so that's access to mental health care, which is, again, I mean, the numbers are grim as far as what the conditions are, the risk factors for kids. The numbers are pretty bad as far as access to care. I'm going to talk about suicide, depression, and anxiety, 3 separate topics further now. Yes, a little more in the way of what suicide's about. Suicide is not always about depression. Not all kids who try to kill themselves have depression. Okay? It may be in response to a sudden disciplinary crisis or a relationship breakup or such. And depression was not present, but depression is commonly present in most of the kids who are suicide attempters. And sadly, most of them are not identified as being at risk ahead of time. And few receive mental health assessment. Remember, a lot of them do so without parents being aware. These are national numbers from CDC. This is all ages, not just kids, about what's happening in suicide rates. And what you see here is that it was nicely dropping off during from the late 80s into the 90s, and it's been rising ever since then. And there's lots of speculation about why that may be. But that's the trend in the country, and it's up in the, as of 2012, which was the last numbers I could find on a graph like this, it was 12.5 deaths by suicide per 100,000. That's deaths by suicide, not attempts. These are kid numbers that I put together. I have some references in a table, and I actually have the last number of years on this. But the interesting thing is, for little kids, okay, pretty rare, thankfully, dropping nicely into the mid-2000s and now rising, and it is now double, just about, or more than double what it was in 2007. Okay. And in older kids, this is the way the CDC does their numbers, 15 to 24. In older kids, same thing, it was diminishing gradually through the 90s and into the early 2000s, and now it's rising. And again, lots of speculation about why that may be. Not much certain. Further disruption to families as time goes on, increasing prevalence of substance use, not just with kids, but with families. Cell phones and such have been implicated recently, with some suggestion about that. The smartphones, I should say. The FDA's warning about risk with suicide from antidepressant medications occurred back in 2005, I think. And the number of kids being treated drastically dropped for several years. There's a lot of possibilities that might explain this, as well as lack of access to mental health care, which is worsening now. It's actually harder to get an appointment with a psychiatrist now than it was when I came here in 1985. Texas, sadly, is holding up its part of the bargain. Texas ranks kind of in the broad middle of the pack as far as suicide risk in teenagers. And you can see the minority group, other than the other minority groups, are rising in terms of generally rising as far as suicide risk. But we're up in the 13 to 14 range generally, with Caucasian kids having the higher risk. Risk factors. I'm dividing it up into 2 territories. Static risk factors here, okay, which is what is part of this individual's state, what's been there forever, what's intrinsic to that individual, what's kind of part of their broad history. And then the next one's going to be dynamic risk factors, what's going on right now that might be a factor. So static risk factors is being male, being non-heterosexual, having a personal history of suicide attempts, or being an abuse victim. NSSI is non-suicidal self-injury, not cutting. Being a witness to violence or suicide behavior, or suicide, being a witness to suicide, increases your risk as a teenager of suicide. A family history of psychiatric illness or suicide. Suicide runs in families. So those are kind of static risk factors. Those are the things that the kid carries with them once they've happened or once he's born. That may increase risk for suicide, and that's in adolescence. This next dynamic risk factors is happening at a different age group. The dynamic risk factors are the ones again that are right now. Does a child have a current psychiatric disorder, like depression? Does a child have current psychological symptoms? Insomnia. Burdensomeness means feeling like a burden to everybody. Feeling like you're presenting a burden to your family, say. Being impulsive, having active suicide thoughts, of course. Dynamic risk factors, having access to lethal means. We need to think about this. In kids who are depressed or having some emotional turmoil, do they have access to firearms or means of suffocation? Ways that you actually can kill yourself for teenagers. Are they in the midst of interpersonal conflicts for little kids with their parents, for older ones with their romantic partners? About bullying, being a victim of suicide, being a victim of bullying, being a perpetrator of bullying. Bullies have higher rates of suicide. Many of them have been bullied. Being in current legal trouble is a risk. Current substance use, and then being socially isolated. Okay, so you get the picture. And this is, again, these are static. Static risk factors, the ones that are intrinsic to the child and then lie in their past history. The dynamic risk factors are what's going on right now. Those are the risks, higher risk factors for suicide. What's protective? Quite a bit. A sense of emotional stability, good coping mechanisms, executive brain. Being connected to family members, and especially with a lot of people in the household. Not necessarily family, but people in the household. This is scientific studies looking for commonalities, right? Strong parental presence, high parental expectations for school, being engaged in activities and having a good social group, and fondness for school. Interestingly, religious affiliation is a protective factor for boys, availability of school counseling services for girls. Statistical significance. So again, kids who are further along in their identity development, further along in their general maturation, when you have strong connectedness and strong parental presence, or that authoritative, Mormon, firm parenting. Okay, what do you do about this as a parent? Know your warning signs, and these we've heard of before. Okay. Changes in mood, change in behavior, fears or sleeping, eating, change of activity. Talk or action regarding death or self-harm. Like self-harm, active self-harm, looking up ways to die, giving away belongings, looking for a weapon, obvious things, right? And then look for triggers, too, as far as a warning sign. What's happened just lately? Is there some crisis that has just occurred? Okay. And then your risk factors, the ones we just covered, the static and dynamic risk factors. So those are some things for parents to know about. And then how do you engage with this? I think he was talking about building a mentoring relationship, kind of starting it up in adolescence and realizing where you're going with this. I think this is part of your parenting as for your teenager as well. You don't wait necessarily until there's a crisis. You're going to come up on news items and such that are going to be in the territory of suicide. It's a time to talk about it. Ask questions. Have you thought about this before? What do you think about people who do that? Here's my ideas about it. And then ask directly, have you ever had suicide thoughts? You're opening the door when you do this. You're giving an opportunity, which may not be necessary, may not be needed, rather, for 6 months or 2 years or ever. But the fact that you were willing to open it up means something to the child. And then listen actively and calmly and seriously. And it's hard to, if you're scared as a parent, it's hard to do that. You want to say, oh no, don't do that. Okay? But what you want to do is give the child the opportunity. You're actually lowering the risk when the child has an opportunity to communicate about this. Speak, don't act. Name the resources. You know, if you ever feel like that, you can always come to me. You can go to Grandpa. Your school counselor is available. You know Mrs. Jones, your math teacher. Remember Father Anthony. We can go talk to Dr. Pitts. Making sure they know who the resources are around their lives. And if you have active concerns about this, then you've got people to go to physicians or mental health professionals of various kinds. You also want to be sure you take action for safety. And this is important. In a kid who's in a crisis and is showing some of these warning signs or has some of those static or dynamic risk factors, take action. Get the house safe. And then supervise. And keep talking. Keep talking. So that's talking about suicide then. Okay, we're going to talk about depression a bit. And again, suicide's a behavior. Depression is a condition. These are two different things. Lucy may not care what the difference is, but there is a difference between being depressed and just feeling bad. An awful slide. This is what we got to go by as far as diagnosing it. Just look at the yellow stuff. These are the diagnostic criteria that we have for major depression. These are scientifically validated, long-standing, useful. This is how you define it. 5 or more for a 2-week period. That represents a change from previous functioning. Basically, it's a mood change, including irritability in kids, not just sadness. Interest and pleasure is diminished. Weight or appetite. Insomnia or hypersomnia, psychomotor agitation or retardation, fatigue and worthlessness and guilt, concentration or indecisiveness, and then thoughts about death, suicidal thoughts, or a suicide attempt or a plan. Okay. So those 2 weeks, change from previous functioning, cause significant impairment and distress. That's kind of the criteria for depression. That's what defines depression. So when a kid says, I'm depressed, they may be saying, I'm bored. They may be saying, it was a lousy day at school. Or, what a grade, we lost the game, I'm depressed. Okay. And I and you need to be thinking about depression in terms of, is it a cluster of these things? Is it a syndrome? Is it a collection of these with a significant change of functioning that has been persistent for a while, at least 2 weeks? Okay. Here's some principles about this. Again, depression is a syndrome, and it's got a lot of elements: affective or emotional, cognitive, affects your thinking, your judgments, your way of looking at the world; vegetative, which is body, sleep, eating, weight, energy; social functioning, social interest and capacity to engage and enjoy; and then behavioral changes too: withdrawal, quite often, crying. Depression in kids may include despair, isolation, and helplessness, especially helplessness. Okay? And being young implies kids get easily overwhelmed with emotion, and they're more emotional creatures than thinking creatures a lot of times. So easily overwhelmed. They have more trouble using cognitive and problem-solving strengths. They have poor awareness of what their coping alternatives are. I could tell you lots of stories about sitting down with a 15-year-old girl, and I ask, when you feel bad, what else can you do besides cut? What do other people do? And I get a thoughtful response of, well, I don't really know. How to relieve the stress? How do I soothe myself? Okay. They're not yet at a point of problem solving and coping alternatives. So you have to help them with this. And then withdrawal and irritability are common in kids, and so that's hard to keep in mind that kids who are constantly irritable may have a depression syndrome. All right, so what do we do for them? First, safety. That's your business as much as mine. um, assessing suicide risk, level of supervision that's needed. It means kind of deciding sometimes what's the right setting to do this. Some kids need to be in a hospital in a severe depression situation. There's safety concerns. Thankfully, not many. And then how much they're going to need supervision and constant adult awareness at home. I spend a lot of time on educating people about this, trying to get the kids to understand that this is a state you are in and is not the story of the rest of your life. This is a state of being at the moment and can change and will change if we do all the right stuff and if we're fortunate. Helping parents see this too, that this is a state that requires some extra energy and effort in it. Sometimes it means teacher needs to know that there's a reason for this academic decline and lack of motivation that's going on. That the school may need to know about some days that are missed and some absences for appointments with professionals and such. Teaching the kids about the course of the illness. That depression may last anywhere from months to a couple of years, but it usually is not permanent. And helping them get awareness and learn about this from various educational resources. Self-management is a big deal in depression. It's one of the things that makes the difference between people getting better and not getting better. Sleep hygiene, getting enough sleep on schedule, substance abstinence, not using substances, and getting exercise. Those are pretty big. And then social and spiritual affiliations, if they're healthy ones, can make a big difference in people recovering. Treatment, psychotherapy, cognitive behavior therapy, and some others have been proven to be effective in kids, 60% or so. A pediatric pulmonary doctor thinks 60% effectiveness with the treatment was pretty good with a single treatment, and it works. It reduces relapse risk and reduces suicide risk a bit too. And that's important. We need treatments that can help the long term because depression may be recurrent. Cognitive behavioral therapy in depression targets thoughts, beliefs, attitudes, and behaviors that contribute to the kid's distress. And when people are depressed, oftentimes they have distorted thoughts. All or nothing thinking or perfectionistic thinking. They have global perceptions of everything's awful. I never do any good on things. I always fail. Nobody likes me. They have problem-solving deficits, and a therapist can work with a child and can help those, and it actually helps reverse the mood change. And then medication works pretty well. The SSRI medicines that we use, which I'll cover a little bit, have pretty good efficacy also. Any one of them that we have proof of in kids is working about 60% of the time. Usually we use them 6 to 12 months after the child has remitted, after they've had significant improvement, before we remove them. The best treatment for more severe depression is going to be psychotherapy plus medication. With pretty good odds of success. A smooch on the cheek is not necessarily going to solve depression, but Snoopy's genius is go toward the distress. Take action. Do something. And that is a relief, and it is a sense of it's a reversal of a sense of helplessness and isolation, and it helps. So that I think is what we adults need to do for kids. Go toward them when they're struggling. Take action. Some anxiety.
You would be surprised how many high school kids really want to snuggle. You know, they'll tell you no, but when they really have the opportunity, it's extremely comforting to just, sit on the couch together, maybe watch a movie, and then before you know it, maybe they've got their head in your lap and you're stroking their hair, or, something like that. It can be very, very nurturing, sort of like as a young child, and it can be very helpful for a kid who feels like they don't do anything right, everybody's against them, and a lot of high school kids, that's really what they need more than anything else.
And they'll never ask for it, huh?
Yeah, never. I mean, one of the things that it's okay, but they'll sit there.
that's some things about depression. Anxiety conditions, again, lots of words. Look at the yellow stuff. I'll just cover. These are all different varieties of anxiety. Separation anxiety, the central thing is fear about separation from an attachment figure. Social anxiety is fear of humiliation and embarrassment, recognized or observed by others. Selective mutism is kind of a variant of social anxiety, where the kids are terrified about speaking in public and they don't, except with very familiar individuals. Specific phobias, a specific phobic situation. Generalized anxiety disorder, constant state of worry with physical symptoms, a lot of times sleep disturbance. Panic disorder speaks for itself. Post-traumatic stress with intruding, re-experiencing phenomena, a highly aroused, vigilant state, and then obsessive compulsive disorder, most people are familiar with. Okay. And people look at this kind of thing and they think, well, anxiety, so what? Okay. But when it's your kid and you can't get out of the door in the morning because the kid is panicking every day, when the school's calling you and saying he's vomiting again, don't pick him up. And you're now at 15 days of school missed since, and it's January. I used him off a couple days ago. Or when you can't get the kid out of the bathroom because he has to turn the faucet off just right, with obsessive compulsive disorder. Okay. Those are pretty big deals. They're very disruptive to the kids' lives, and you saw the numbers. There are severe disorders in a significant percentage of kids who've had anxiety conditions, and they can be chronic. Similar principles to depression in some areas here. A lot of kids have physical symptoms, primarily with anxiety. They've often had tens or hundreds of thousands of dollars of medical workup before it's put together and finally determined that it's an anxiety condition. Anxiety is about dysregulation of fight and flight responses in the body. Kids look at escape and avoidance as the best ways to handle anxiety, not to solve it. And being young implies that they are easily overwhelmed with emotion. They're highly reactive. They're vigilant. That is, when you're little, you don't feel much control. When you're young, you're not the boss of things, so you don't feel much control. So you're on the lookout for threats around you to try to keep in control in some fashion. And then they have poor awareness of coping alternatives, other than get out of there or don't go. What do we do for them? Similarly, education, like I was telling you about depression. Similarly, self-management, avoid caffeine, censor media. How many kids have I seen who were having terrifying nightmares and anxiety symptoms when we just stopped the horror movies that the parents were letting them watch? We liked them. Sleep hygiene, maintaining activity and school participation even when the kids don't want to. If your judgment is that the kid can handle it, you want them to go ahead and go, and you nudge them and you put some gentle, constructive pressure on them to keep attending. Because the more they avoid, the more they avoid. The more they avoid, the less experience they have that it's going to go better than the anxiety tells them it's going to go. So you want them to have that experience that, it's going to go badly, you're going to freak out, it's going to be terrible, and then they go, it's not that bad. You want them to have that experience to counteract the irrational fearfulness. And you want to avoid, as much as possible, indulging the fears or enabling that avoidance. Psychotherapy works well for the kids. Cognitive behavior therapy is very effective. Teaching the kids body management, like breathing exercises, muscle relaxation, building their problem-solving skills, helping them learn about rational versus irrational fears, working on that for a while, and then starting to expose the kid to the feared stimulus. I can't bear to go to school because everybody's looking at me and they all think I'm a fool, and I freak out when that happens. And if you work on those skills and cognitive components, then going to school and rating how did it actually go can help to diminish this. I had a patient once who had terrible social anxiety, and Dad happened to own a fast food restaurant franchise, and put the kid to work there. Eventually up at the front, and he had to sit there and perform in front of the public all day long. He had no more social anxiety at the end of the summer. Okay. But it was hard going. It was very painful for the kid and the parent. but it was effective. We were basically exposing him to the situation with some new skills that we trained him for, and it worked. So we have good efficacy with the psychotherapy, 60 to 85%. Medication, same way, pretty good efficacy with that too. And the best treatment for severe anxiety disorders is cognitive behavior therapy plus medication, which it's up to 80% range. Pretty good effectiveness of treatment. A little bit about mental health resources in the area, and how do you use mental health resources and what do they consist of. There's a couple things right and wrong about Lucy here. One is if you're a mental health professional, usually you don't have to put up a sign. Mind you. I've never put my feet up in 30 years. It's always busy. She's correct about the reimbursement rates. For those who take insurance, at least. Okay, who does what? Psychiatrists or physicians, MDs or DOs, psychologists, or PhDs, or PsyD or EDD, or physicians go through internship, residency, and so on. Psychology starts with academics and moves to clinical as they move on in their field. You have other kinds of medical practitioners, nurse practitioners, and physician assistants who, some of whom specialize in psychiatry and can handle the medical aspects of it quite well. And then there are counseling professionals of various disciplines, licensed professional counselors, master social workers, marriage and family therapists, licensed chemical dependency counselors, master's level people who are the most numerous and do most of the psychotherapy work in our area. Psychologists are the ones who do psychological testing too. Most valuable in helping with diagnosis. That's different disciplines then. What do we have in East Texas? And you got a handout item on this at the end. What do you do in emergency? Really, any hospital emergency room, they're all used to dealing with psychiatric emergencies in kids. We have the one psychiatric hospital for kids. We have community mental health centers, public mental health centers that are available. Andrews Center in Smith County and surrounding counties. Access is Cherokee and Anderson County. And Community Health Corps is the Longview area and west and north. Primary care docs are generally your first option to assess and determine what's needed and refer if needed, and a lot of times start treatment, and very capably so. We are really blessed in East Texas with our family physicians and pediatricians to help with kids. They're good. They're really good with mental health services. As far as mental health clinics, outpatient care, the community mental health centers, again, for the more severe conditions in their priority population. You have various group and individual practices in the region. You got one across the lawn over here, and several others. Tyler Counseling and Assessment, clinical associates over there on Civil behind Hobby Lobby, Dr. Fry's, and various other clinics in the area for counseling and individual practitioners as well. Substance use treatment for kids is hard to come by. We have one or two professionals in town who do some of this for kids. We have a residential center in Canton that's hard to get to with insurance. Support groups are free, but you've got to check them out. You have to call the AA central office for kids with substance use problems and find out who is appropriate, which groups are appropriate for kids, and some are and some are not. Okay. I'll go through this quickly. Just people wonder what a psychiatrist does. It's like what physicians do. We take a history, which includes the current condition. We look at past medical history, review systems or review symptoms of health conditions. We get a lot of developmental and social history in kids from prenatal all the way up to the present, as far as how they've been developing, what the events have been in their development, the family's environment and such. And then the family history, especially of neurological, mental, and developmental conditions. Depression runs in families, anxiety runs in families, bipolar disorder, ADHD, autism, they run. We do what elements of physical exam are necessary for the child's condition at the time. We do a thorough mental status examination. We come up with a diagnosis, and a lot of times a differential diagnosis, which is to say, okay, the kid has depression, but may also have bipolar disorder that hasn't emerged yet fully, so that's on our list of possible diagnoses. May have an anxiety condition too, may have some mild autism features. So it's kind of a listing of possibilities. And then we try to assess their prognosis and their current safety status and develop a plan of care, which may not be treatment. It may be start martial arts, self-management tips, referral to some community resources, some suggestions for how to manage things a bit differently at school, some recommendations to qualify the child for special ed services for certain conditions at school. Some behavior management steps. We may refer them to other professionals or schedule some laboratory testing or psychological testing. We may refer them back to the primary care doc to get some further medical workup on certain things that are needed in the differential diagnosis process. And then psychotherapy and medication may be effective as well. So that's kind of how the project works. I'll just mention a little bit about medication. People always have questions after talks about medication. This is the stuff that's relevant to what we talked about today as far as depression, anxiety, and such. I'm not going to go into ADHD medicines and bipolar medicines and all that. The SSRI medicines are our best proven group for anxiety conditions and for depression and for OCD, for post-traumatic stress disorder, and other things. They're generally things people are familiar with. Thankfully, they're all cheap. These are our FDA-approved ones for kids. These, we don't use Paxils. That typically in kids. Citalopram is used some in kids. They're not FDA approved, but the statistics are there to say that citalopram can be effective in some conditions. They're generally well tolerated. The FDA's got their warning on all of them that they can increase suicide risk or thoughts of suicide or such. It's rare. I see 2 or 3 or 4 kids a year who are taking these medicines who have something worse emotionally happen to them after they start, as compared to hundreds who have very positive results. So it's not a reason not to use the medicines. It's a reason to be careful, to watch carefully, to go slowly, to talk about it and check on it frequently. So by and large, though, they're pretty well tolerated. Sometimes sleeping problems or stomach symptoms or fatigue. Some kids get more hyper on them, but generally fairly effective medications. And if you don't get response with one, the chances are pretty good that you will with another in childhood. The NRI medicine is a different category, but there's a lot of similarities. This one's approved. Effexor is not approved, but has a degree of proof of usefulness in some for kids who don't respond to others. So that's mostly what we use. The side effects are similar. There's a few others. I'll just cover this one here. This one gets used a fair amount in kids who don't respond to standard medicines. It's pretty safe. It does have a higher risk of seizures and other antidepressants, so we've got to watch that and select kids carefully. That's the one in that group that we use the most. Okay. So those are some medications. And the medications have a role, but they may be necessary, but they're not sufficient. These information resources are in your handout. Those are some of the national organizations, some of the governmental organizations that provide good information for parents about all these topics and others. So in summary, adolescence is an exciting and turbulent time, but usually a successful transitional time. Youth mental, emotional, behavioral, and developmental disorders are very common. They're complex, they carry risk of severe consequences and poor outcomes. And they're often unrecognized and unaddressed. Access to care is difficult and likely to remain so. There are a lot of professionals and a lot of effective treatments, but you are the key.
First, we see here at school is that that's not necessarily how they behave when you're not looking at all. So the lunchroom is a key place where we really see the kids. We eat with the kids, which is great, because we know who's sitting with whom, when somebody really is isolating and off by themselves. And very, very many times, the feeling of isolation is really indicative of something else. Oftentimes it's about change, Oftentimes, it's about having to make decisions, pressure that somebody feels from the outside. Many times, parents will come into my office and they believe that their child has no friends. But yet, in the hallway, they're chumming along, and at lunchtime, they're having a good, casual type of conversation, type of thing that goes on. So oftentimes when your student, comes to you and they have no friends, it's really a normal type of conversation between parent and child. And I would encourage you to ask the teachers who they have. Do you notice this, that they're isolating themselves? Ask Mrs. Roberts or myself about it. Ask Father Vreeland about it because he sees a lot of the kids. Ask Mrs. Schick or Mrs. Perry about it. Do you notice that my child is not being with their friends anymore? Oftentimes with the social media side of things, you have a group of people who will go to the mall or go to the movie, and they send around the text real quickly, and somebody gets left off for one reason or another, and it's this person this day, and it's that person another day. Unfortunately, that is a normal behavior of kids, and it all depends upon so many things we can't even get started on. Sometimes it's, well, I know that parents not going to let them watch that movie, so I'm not even going to ask them. Okay, now the student feels isolated because they're the one out. There's a lot of things that go into that, and it's more commonly that we see it with the social media types of quick text messages, group text messages of going somewhere or doing a particular activity where people feel left out. But I would encourage you, ask the teachers, ask the people who see your kids on a regular basis if they notice any kind of behaviors that you're concerned about, because then you'll get some really some good feedback that will either affirm what your child is telling you, or maybe it's something completely different.
What kind of, Stanley, what kind of resources are there within the school? If a parent or a student comes in and says, I'm having this problem or I'm feeling this way, what are the different avenues that you or Ms. Perry or Ms. Schick or anyone can send them in the school family?
Well, we have Father Vreeland, myself, and Mrs. Roberts, who are very available to help out with a student who needs to talk. And that's oftentimes what you're referring to. Student comes in and they just need to talk to somebody. Mrs. Schick has every other day where she's not teaching, and she listens to students. Most commonly, that's the thing. We need somebody who's not going to run off the class that they can then talk to and talk something through. So we have that. But then we also have situations where a student, during that conversation, might reveal something that they say, well, I want to talk to you, but it's really a secret. You can't tell anybody else. All of us will say the same thing. If a student is saying something where they're going to harm themselves or harm somebody else, or they're doing something that's illegal, we will help them to talk to their parent, but we will not keep it a secret. That, that has happened before, when somebody would like for the student to be able to talk to the parent. And we will sit there with them while that goes on, if that's how they feel comfortable. But that's the way that we would really like for the student to be the one to communicate that. Sometimes that has happened in my office over the phone, where the student has called the parent. Sometimes it's happened where the student has been in there, and we've been on speakerphone, and we've both spoken with the parent. Sometimes there have been a situation, pregnancy, one of those situations where, it was something that we needed to talk to the parent about. And it was actually, you know, maybe something that I suspected, and got the student to acknowledge that type of thing. And so brought the parents in. And, you know, oftentimes there's a clergy member available at that time too. So, the way that we really look at working with the student is helping the student to take responsibility for their own, you know, life in this. They need to learn how to ask. They need to learn how to move through that uncomfortableness that that can appear in all of our lives.
Well, this is something that, one thing I wanted to say is, this is not something that happens to other people or happens in other places. It happens everywhere in every kind of family. With me, it was some postpartum depression that I had after both my boys were born. And it was very difficult in the first, but every family has something. And if there's something that you're struggling with, it's very likely that you're not alone. And there are other people here and within the school family who have dealt with all kinds of situations. And I asked Peggy Ryder if she would be willing to talk just briefly about some of the things that she's been involved in this community and how she got there. And for those of you who don't know Peggy, the Ryders have had several kids who have gone through, graduated from Gorman, and their youngest daughter, Erin Rose, is a senior right now. But she has been involved in this community and in this church for years. So, Peggy.
So many familiar faces. First of all, I really want to say thank you for taking time out. Everyone is busy, so thank you for coming to a very meaningful talk. And Dr. Scardina's talk was perfect and wonderful, so I hope you'll keep your handouts, which is wonderful. This has been thrust upon us as a society and a community, and as Jennifer just said, it touches everyone and touches all kinds of families. We entered the school system in 1998 and we'll be exiting this May, so we've been around for a while. Our oldest graduated in 2010, then 2011, 2014, 2016, and now 2018. So going through several graduations here at Gorman. Our oldest took his own life in what would have been his senior year in college. This thrust us into this arena of mental health and suicide prevention. And I will tell you, there's much that I know now that obviously I didn't know then. Again, much of what Dr. Scardina just went over is great information, so hold on to that. The best thing he said is that you are the best, expert of your child. And that's the main thing to remember. If it's going to take 9 months to get into a psychiatrist, you have to do much within that time. So be aware of that. There are resources available. I have one plug for Samaritan Counseling. It's a not-for-profit counseling here in town. They do have a sliding scale fee if that becomes an obstacle for families. They have a wide variety. Some the counselors do have waiting lists, so it does take time. The other thing that I want to emphasize also for our family, we didn't have any trouble with Jack, our oldest, who lost his life, before he left Gorman. He was, one of the top 5 students. He was a great athlete. He was a great student. And I think that's what some of the things that he said, how things are so hidden. And what's very difficult for parents is once your children turn 18, is you are on the side. Jack saw 4 different counselors in the last 4 years of his life, and the last one being the day before he took his life. The self-management and the coping skills that they need to learn, the best time to learn is before they turn 18. So that's why it's great to see all of you here to learn some of these skills. The other thing is to find that vocabulary with your children now, again, before they turn 18. Being able to say, does it ever get so bad that you would think of taking your own life? The Grammys just had that song, the 1-800-273-TALK. We've had the 13 Reasons Why episodes, and those are great opportunities to take with your children to bring out some of those things of how are you feeling? What's been going on? And the other thing I would say is, despite what's on the outside, help them find that vocabulary for what's going on the inside, with what's going on in their thoughts. So much of what our kids are seeing and hearing is coming through their phones. That turns into their thoughts. So helping them learn that vocabulary of expressing what's going on, especially before they turn 18, is very, very important. And then not to keep you any longer, but so we can ask any more questions, my name is, and my phone number and my email is in the directory, so if you do have any questions or if you ever want to call me, please don't hesitate. Thanks for being here.